It's lovely to see you again. And Jazakallah to Miqdad and everyone for inviting me here today. It was a lovely opportunity to see Fatima and her family, and Auntie has fed me so well. I've already started sort of feeling my energy levels being very nicely comforted. So what I'm going to try and do is talk for about half an hour or so to try and give us all enough time, inshallah, to have a discussion. And what I want to do is share with you a few of my thoughts on the project that I have just started on end-of-life care in Cambridge. And what I want to focus on in particular is how end-of-life care is raising ethical issues when Muslim patients and families are thinking about what sort of treatment and escalation of care that they need to be deliberating. And the way in which I want to do that is to share a recent case with you that was discussed in the High Court. And there is quite a lot of terminology that is associated with the case, including terms like medical futility, best interests, quality of life, and sanctity of life. And what I want to do is try and begin a conversation where we can demystify some of these terms and consider the underlying ethical values that are associated with them. And also to show how there are many different types of people who are involved in end-of-life decisions, and that for each of these players, what these terms mean can be very, very different. And what I'm trying to do with my research project over the next couple of years, inshallah, is to try and speak to Muslim patients, their families, as well as healthcare staff, hospital chaplains and imams, to try and understand better what the end-of-life care experience is of Muslims in the UK, and how we can then use that understanding and learning to think about the gaps in healthcare to try and change and improve policy. But I'm at the early stages of this project, so I'm really hoping, inshallah, that speaking to all of you will help feed into this project. And it's an ongoing thing, so today's not the only day where I'll be wanting input from you. I'm hoping, inshallah, over the next couple of years or so that we can keep talking about this. I've already set up a conversation with Uncle where we're going to start thinking about the landscaping of end-of-life care services in the UK. So the case that I want to talk about was in the High Court a couple of years ago, and its focus was on a man in his 70s who ended up in hospital because he had a very severe heart attack, which meant that his heart stopped. His family were able to initiate CPR at home, which was carried on by the ambulance and in the hospital, and his heart managed to start beating again, but he remained unconscious. And this happened on the background of him having very severe type 2 diabetes. He'd suffered a stroke a few years back, which meant that he was housebound and dependent for his feeding and his basic care. Now, what happened was, over the course of the next couple of days following his admission, the hospital staff became concerned about what to do in the event that his heart stops again. And so what they thought was, given the amount of the CPR that he received before coming into hospital, given his past medical history, it would be very, very difficult for them to administer CPR again to try and establish a quality of life for him that would be sufficient. So what they also assessed is, over the course of the days of his admission, he showed no improvement and in fact deterioration, and decided that because of the extent of the brain damage, they would not resuscitate. So when the family became aware that their father was considered not for resuscitation, they became very anxious, very concerned, and had a consultation with the healthcare staff and said, look, because of our religious views around end-of-life care and the need to seek treatment for however long is possible, we want to reconsider this idea of you withholding treatment if our father's heart stops. And what we want to do is consult a religious advisor. So the hospital staff decided to meet the wishes of the family and said, okay, for a period, we will reconsider this resuscitation decision. And when the family went to see the local imam at the hospital, the imam said to them, look, life and death is in the hands of Allah. It's not up for the doctors to decide. You need to tell them that they need to carry on treating him, and that withholding any form of treatment is not acceptable. Now, when the family went back to the hospital to discuss this with the healthcare team, what emerged was a tension, what we would consider an ethical tension about what we should do in this given situation. So the medical team were emphasizing that, look, even if we were to restart his heart, it would mean we'd be pressing on his chest, maybe fracturing ribs, creating more harm. And even if his heart restarts again, it will be for a very temporary period of time. So it would be in his best interests if we didn't intervene in that case. Now, the family was saying, look, we're close to him, we've always been near him, and we have a better understanding of what the best interests are for our father. And he would have wanted for you to carry on treating him. And he would have also wanted the opportunity, whatever pain was involved, to try and have as much expiation from sin, because this is how we understand illness in this setting. So it was very important in this case that both sides were thinking about the best interest of this patient. And the medical team were using their medical knowledge to try and assess what the best interest was. And the family were trying to use what they considered their own beliefs and values, and also, in turn, what their father would have wanted. So, because there was an inability for the two parties to come to a decision, the case ended up in court about how the care of this patient ought to be decided. Now, some people would say an extreme case for a situation like this to end up in court. But when we speak to families and physicians, these sorts of decisions and tensions occur a lot more, they happen more commonly than we would otherwise assume. So what I wanted to do was, I wanted to look at this case and a lot of the sorts of questions and tensions around this to try and understand why this disagreement happens. And it'll be really interesting to hear your views on this, but what I put it down to is the family's understanding of best interest and the medical team's understanding of best interests was centering around this notion of life-saving treatment and how we understand life-saving treatment. So what I want to do is spend a little bit of time thinking about what we understand and what we've historically understood as being life-saving treatment. Now, we know in the medieval times, polymaths like Ibn Sina managed to conquer many different spheres of knowledge. He was a theologian, a philosopher, a physician, and within himself was able to combine and balance different sources of knowledge. And medieval jurists were able to sit down together and were more concerned at the time with the efficacy and safety of medical treatment. And what they concluded at that time was, if we have a situation where somebody needs treatment and it will save their life and it will cause minimal harm to intervene, then we should do that. If we're not sure whether it will be of benefit or harm, then it depends on whoever is there and they can decide whether to intervene. But if it's likely that by intervening you're going to be causing more harm, then you shouldn't administer any sort of harsh treatment in that case. Now, what's happened over the last couple of decades is that biomedical care has escalated beyond what can be commonly understood as care. And what has happened is there's been a disconnect between what intensive care services can and should provide versus how it is that scholars and the lay public understand what that care is. So I want to spend a little bit of time unpicking that. Now, when I've spoken to a few intensive care doctors, they've said that the services they provide are for very, very acute situations where somebody needs treatment for a short period of time to either reverse what condition they have and to support the rest of their bodily functions. So, for example, if somebody suffered a car accident where they were bleeding heavily, they would end up in intensive care in order to give the doctors time to stop the bleeding and to make sure that enough circulatory support, enough support was provided to the body to keep the blood pumping around so the rest of the organs could get oxygen. Now, what happens is that even the interventions that they employ in these sorts of settings have a lot of harm, a lot of burden associated with them. We've all heard about hospital-acquired infections, but what we don't commonly know about is the burden to the body when we undergo dialysis, for example. And research shows that an individual in intensive care can lose up to 25 to 30% of their body mass in a week. And this is a healthy person. So you can imagine the weakening and loss of function that can happen if somebody stays in intensive care for a long period of time. So this notion of life-saving and what we mean by saving life requires further reflection. Now, there's a really good friend of mine, Asim Padella, who is working at the University of Chicago, and he's been spending quite a bit of time over the last few years or so looking at questions around end-of-life care. And his research emphasizes that what the medieval jurists considered to be life-saving treatment was relatively simple for that time. They saw somebody evidently unwell and then advised for that person to be treated. But with the advances in modern medicine, what can happen is we can sustain somebody's life without really achieving a quality of life that would mean they would improve beyond the state that they're in. So what Asim Padella argues is, with regards to end-of-life care, this life-saving paradigm needs to be reconsidered. So we're thinking more about what a life is that is worth living. So rather than thinking about life prolongation, it's about thinking about what is a life that is worth living. Now, this is a very, very complicated term, and it's something that, we may need to spend a bit of time unpacking. But there are quite a few scholars who have commented on this, and one scholar in the 20th century was the Islamic scholar Fazlur Rahman, and he said that in the Quran, Allah subhanahu wa ta'ala describes, "He whom we bring unto old age, we reverse him in creation, making him go back to a state of weakness after strength." So he argues that when we near the end of life, we exhibit a weakness that is similar to when we first entered this life. And it's only through the improvement of that life that we can justify intervening at that stage. So what Asim Padella does is he concurs with Fazlur Rahman's idea and says that what we need to do is think from within the Islamic tradition, how do we understand this notion of a life worth living? Now, this is very interesting because a lot of us who are in the healthcare setting may be familiar with this notion of quality of life or a life worth living. And so often in the medical sphere, it's about being able to go about your daily activities or going back to a situation physically where you were before a medical event happened. So for the case that I described, it would be getting the father back to a stage where he can go back home and be with his family. And that would be a quality of life measure that was equivalent to what his condition was before. Now, when this case was discussed in court, interestingly, the judge talked about how when we think about simply prolonging life, it's as though what we're trying to do is design a situation where a ventilator is simply sustaining a beating heart, even though the brainstem and therefore the patient is dead. So he describes this situation as a ventilated corpse. Now, again, we come to this very interesting juncture. Both sides were talking about best interests, and now both sides are talking about quality of life. Now, we have some sort of understanding of the medical terminology in quality of life and activities of daily living, but from the Islamic perspective, how can we begin to understand this term? And a lot of the work that's been done on this is very, very recent in terms of applying theological understandings of the worth of life to end-of-life care. So it'll be really, really useful for me to get some feedback from you about what you think. And so what Asim Padella argues is that how we can understand benefit theologically and how we can understand a life that is worth living theologically is by thinking about the original purpose of why we are here. And Allah subhanahu wa ta'ala says in the Quran that I created jinn and man only that they worship me. So what they argue within their research is the obligation to seek treatment and the obligation to administer treatment can only be extended to situations where you can regain the ability to know and worship Allah subhanahu wa ta'ala. Now, it's a novel idea. It's the first time I came across this. And so I thought I'd share this with you to try and gauge what you think about this. They say that this notion of obligation or takhlif is related to one's capability. And that capability is theologically determined by one's connection with Allah and one's ability to fulfill the obligation towards Allah subhanahu wa ta'ala. And there is an understanding that somebody who is not conscious, is not able to be aware of their surroundings, is not obligated to fulfill certain duties that those of us who are aware of need to. Now, there are a few questions that come out from this, which I'm sure you all may be weighing in your minds right now, which is, if we think about life and its worth around our ability to worship, then how do we consider lives that are not in that state? So those who are either born with or sustain mental capacity, that means they aren't in that condition. And they don't really explain that situation well, which then makes me think, well, is this a useful tool for us to make end-of-life decisions in the case that was set up? And another question that arises from this is, well, okay, it may be useful when we consider treatment. So we may say, well, it's not a good idea to resuscitate the patient, or it's not a good idea to carry on giving them antibiotics and fancy drugs. But what about nutrition? When a patient is in an unconscious state, they're unable to feed themselves. And generally, we would agree that it's very, very important not to starve someone in that situation. But if someone isn't able to feed themselves, then the feeding will still require intervention like a tube or lines. And there isn't enough clarity in either the literature or the scholarly works that I've come across that has clarified that. So it's an area that maybe would benefit from further work and further research. Now, just to sort of alleviate you of the suspense, what happened to the gentleman and what happened in the court case, what the judge did was a very interesting thing. You know, he weighed out all of the evidence, you know, from the family, from the medical team, and finally concluded that it would be futile for the medical team to intervene again. And I think this is interesting because what he weighs the decision on is more of the medical emphasis on the distress and pain that may be caused, that there won't be any positive benefit in the end, and that the intervention itself may be life-threatening. So in my mind, this raises another question. When we think about end-of-life care and we think about these very, very difficult decisions, what sort of knowledge are we using to try and come to an understanding of what we should do? And if we look at the different players who are involved, we have the medical team who understandably rely on their medical knowledge to assess the patient and the ability of the healthcare team to provide care that would improve their well-being. And then the family who try to balance their values and their love and care for their loved one to decide their best interests. But then the court needs to weigh these out, and in a lot of these cases generally rules in favor of the medical team. And I want us to maybe spend a little bit of time on why that may be, and whether there is a need to further inform these sorts of decisions through knowledge within the tradition. Now, this leads me on to what it is that I want to try and do from my research. And the emphasis will be over the course of the next couple of years or so is to speak to people like the healthcare team who are involved in this case, as well as the family and other patients who are reaching a terminal situation in terms of their healthcare. And what I would like to do is understand better the infrastructure and landscape that we currently have in terms of end-of-life care, and whether there are provisions currently or what we need to do in order for us to make proactive and informed decisions about end of life. And what's critical here is to understand the role of the different people. And when I was speaking to a hospital chaplain recently, he was saying that, you know, it's really interesting that you mention the court case. I discussed this court case with him, and he said if it was somebody who was at the hospital, such as a chaplain, it would be unlikely that they would come to the same decision as the imam in the mosque. And so I said to him, well, what do you mean by that? So he said, well, context matters a lot. When I work in the hospital and I see what's involved in terms of the physical burden that is necessary in intensive care, then I find it very, very difficult to encourage families to carry on pushing for further medical treatment. So I thought this was a very useful piece of advice, because it means even if people are informed by different value systems, they deliberate depending upon their contextual understanding. Now, what I want to do is just end with a few questions to everyone in the room, and maybe use those to spark our discussion, which is around how it is currently that we envisage end-of-life care within our community. What are our views on hospital treatment, and whether it's the hospital that is the ideal place for us to spend that part of our life, whether there are other services like hospices and nursing homes that may be able to provide care at that stage, and whether there is provision in the home and an understanding in the home about how each of us want to plan for something that is considered an inevitability. As Muslims, we spend a lot of time, in the madrasa or at particular events and functions, thinking about life and death, and emphasizing the remembrance of death. Yet, when we think about the practical application of that learning, death becomes a bit of an unfashionable subject. And so I'll just leave it there and open up the floor to you, because I'm sure you have lots of questions to ask me, and yeah, I just want to hear from you. Jazakallah.
Assalamu alaikum. Thank you for the talk. I just sort of interested to have. I guess working as a doctor, I've always find actually chaplains and imams to be quite obstructive a lot of the time. Perhaps it's me being very medical. That there's always got this reflex action that their instant thing is just to say no, you can't do it. You have to. You have to keep going, you have to try everything, you have to just do whatever it is, without perhaps really understanding the medical background of the situation or not. And I was wondering, do you have any, I know you've opened the floor up to us questions, but to put this back as a question to you, do you have any thoughts about how we could perhaps, are we failing as medical professionals to engage them, or how would we better maybe perhaps make them understand our perspective?
No, it's a really good question, and I think it's the situation of everybody using the same terminology, and the intention of each and every stakeholder in this decision-making process is unquestionably good. They want to try and do the right thing. But what happens is this question of authority comes up, where each different party wants to impress their expertise on the decisions. So when I spoke to this chaplain, he said, what people don't realize is how ill-equipped we are to advise them. On his first day on the job, he was taken into intensive care, horrified himself because he'd never been in such a setting. He was hearing beeping sounds, seeing tubes and buttons and flashing lights all over the place. And the family called him because they wanted him to decide what should happen to their family member. And he was saying, immediately his reaction was, no, things should just carry on. But what he did was he then sat down with the medical staff and asked them, look, what is going on. You'll have to tell me so I can understand better, so I can then discuss that with the family. And when he became aware of exactly what the situation was and the dire condition of the patient, and a real understanding of how the medical team were trying to provide the best care possible, but saw the situation as futile, he realized, well, you know what? A lot of this is simply to do with communication and our inability to provide a space for these sorts of impossible conversations. And this relates back to, my original question of what infrastructure is out there. And I think you're right. It is a case of engaging hospital imams and chaplains and making sure that they feel empowered and informed enough to make these sorts of decisions. And the reverse is true for Muslim doctors who are asked by families to make spiritual decisions that the doctors don't feel equipped to deal with. But Khalil, if you have any ideas, it'd be great to hear.
I don't have any ideas, but just as a follow-up to that, so that almost puts the chaplains in a position, actually, they can sort of have these tricky end-of-life conversations for us as doctors. They can sort of do the sort of futility argument for us and say, actually, it's time to let things go. And are we just sort of maybe basically making them part of the medical team just to have those sort of conversations? Or
no, well, you see, so that's a really interesting point, and goes back to this issue of, well, if the court's using medical futility, if the medical team's using medical futility, and if the chaplain's then using medical futility, then why are we all skirting around the issue? We should simply have an algorithm and dish it out. I think Asim's work shows that there's a subtlety in terms of how the tradition, the Islamic tradition and theological understandings of quality of life and what we understand by life can inform this sort of understanding in a way that is more coherent with what it is that the families need to understand in this situation. But you're right, what is the bottom line? Is it simply this understanding of medical futility? And I have to say, I haven't got my head around that yet. And we need to disentangle that. Even in terms of Asim Padella's paper, are they simply using takhlif as a way of communicating this notion of medical futility? And I have to be honest with you and put my hands up in the air. I'm not convinced. But it's a stepping stone towards having a discussion where we can attract scholars to think about this question more deeply, and for them not to feel as though it's already a decision that is being made outside of their remit. I know Luqman had a question.
Hi there.
Oh,
it's not so much a question, it's just sort of a statement. I just think that as doctors, generally speaking, we die better than other people, and there's a reason for that. We know when to stop. I will always fight to save my patients if I think they've got a chance of sustaining some sort of quality of life. But when it comes to essentially ventilating a corpse, which is what you end up doing when you're pushed into these situations, it's awful. Do you know how terrible I feel putting lines and wires and putting patients on ventilators? Because I think maybe at some level they can feel pain, but they're not ever going to get back up out of this. Isn't it nicer just to take them off the machines and say, I'm going to put you into the back of the car and send you home? And that's just the more humane thing to do. I have, as a doctor, admittedly, known that a young girl my own age had maybe 24, 48 hours to live, and she had been in hospital for 8 weeks. No one had let her get into a wheelchair. I wheeled her outside and I let her look at the sun. And then I wheeled her back. She died the next day. She didn't have anybody, family or friends around her. Just a little bit of humanity. Just because we have all the machines in the world doesn't mean we should use them.
That's a very, very, very important point. And just to build on that, I wonder why it is that the deliberation around these issues becomes so difficult. And is it a universal human concern around the acceptance of death and the process of grieving that makes a lot of these decisions very, very tricky. And yeah, I mean, thank you so much. It's a very, 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 very important point. Sorry, there was another. I saw a hand hovering over there.
Assalamu alaikum.
Wa alaikum salam.
The question I have is, in terms of your research, what is it that you're actually trying to achieve? Are you trying to achieve that you want to bring the Islamic ethical views to bring it in line with the medical views, or because that's how I'm seeing it at the moment?
No, not at all. So my research is focusing more on trying to capture the experience of Muslim families and patients and those who provide care for Muslims in the UK to try and understand better what sorts of questions and challenges are emerging. I gave you the court case as an example because that's something that's been recently debated and discussed. And I'm not preempting any particular goals from the research other than to see what it is that people actually say is happening in their life. And what I'm interested to know is, more than the differences, what the similarities are in terms of how it is that humans consider, deliberate, and understand death and dying when they're faced with it. And the reason that I want to speak to patients in particular is a researcher who's been doing some work on this in Bedfordshire told me that often what happens is we make plans, but when we're faced with a situation where we're burdened with medical care and all of the side effects and bells and whistles that are associated with it, we often think about it differently or change that decision. And so that's why I want to try and capture the different voices. In terms of Islamic values, the only reason I pointed some of those out was because the judge himself mentioned that the religious aspect was a concern for the family, and it made it then imperative for a religious scholar to become involved in the deliberation. And so what I want to do in the research is to see in what instances that happens and why. So yeah, I hope that answers your question.
Assalamu alaikum.
Wa alaikum salam.
Thank you for your talk. This kind of follows on from the previous question. Having come to a point in time where there's so much ambiguity between sort of life and death, and ambiguity between what the human body is sustaining and what the machine is sustaining. Is it not quite an expensive endeavor time-wise and sort of energy-wise to invest it in just a conversation, just a sort of drawing out voices when we have like a whole historical context to draw that from? Is it maybe more urgent to get sort of proposals for ways forward or methods, different ways of dealing with the situation instead? I'm just wondering what your thoughts on that.
Yeah, no, I mean, you're absolutely right in terms of what the next steps ought to be. But before we get to the next steps, we need to get a better understanding of what is actually happening and why. And so that's why I want to focus on a qualitative study in the first place. But what will hopefully come out of that are very, very particular descriptions of gaps in the current system. And so we were discussing this earlier about what the barriers are to a lot of Muslims accessing hospice services. And is that around the type of provision that is provided by hospices? Is it around the stigma that's associated with hospice care and separating somebody from their family environment? There are lots of subtleties that are not as well characterized, and we need to understand that better before we're then able to design a system that responds to that. Now, what you originally said was very, very important, you know, this whole distinction between life and death and how that's blurring. And I didn't want to go into this because I was getting bored of my own voice, but I'll state it now because you've raised the issue. When we look at the UK healthcare landscape, how the philosophical underpinnings of that care is evolving is changing rapidly, and it's something that we all need to be aware of and take ownership of. Life-saving treatment and the emphasis to save life and consider the sanctity of life has been the cornerstone of medicine. And it's been developed on a background of patriarchal, sort of very, a very particular model of care, where doctors simply decide for their patients.
Maybe quite a top-down model.
A very top-down model. Whereas what's happened over the last couple of decades is we've moved to shared decision-making and now more towards patient choice. And a lot of you may be aware of the assisted dying bill that was considered a couple of years ago, which looked at this notion of patients being able to choose for themselves when they wanted to die and when they wanted to end their suffering. Now, this is something that we need to proactively think about, because if healthcare becomes less about the sanctity of life and more about patient choice, then how is it then that services will evolve around such values? And again, I don't have the answer to that, but it's more a case of me hoping to stimulate conversations about that issue.
Just as a quick aside to finish, you mentioned the difference between the choice of the patients and the imposed decisions, perhaps. You mentioned also earlier where with these conversations you were trying to spot where the gaps were, to identify them. What does that look like in a Muslim context? How do you tell where a gap is in an Islamic context for where things need to develop further?
Sure. So I'm going to cheat and say that one of them was already mentioned by Khalil. If Muslim families feel that it's necessary for them to consult a religious person when they're deliberating these sorts of issues, then are those religious experts sufficiently equipped? What sort of training are they given? What sorts of resources are they provided to make those sorts of decisions? And if there is a gap there, if there's something lacking in that sense, then that's something as a community we need to think about proactively. What do we need to do to make sure we have the right infrastructure in place to support these individuals? And is there a way of developing a model where we can preemptively organize these conversations happening before, the acute need arises? Yeah, I mean, that's the ideal scenario.
Thank you so much. So I'm a general practitioner and have been for the last 37 years. And I've seen lots of deaths. A couple of observations. First of all, I think every event has to be individualized. There are so many factors, as you know, that play a role, including that individual's penultimate health status, cause of illness, protracted cancer-related illness, or was it a sudden heart attack or whatever. Family dynamics. Is there a doctor in the family? Matters. Is there a scholar in the family? Does influence. Lots of factors. What's the home like, etc. So I think it has to be an individualized package. My second observation is that there's nothing like a Muslim death or a non-Muslim death. A death is a death. And even as a medic, I never distinguish between a Muslim dying or a non-Muslim dying. The support and the event has to be managed in exactly the same way. I heard this for the first time from you, that the few of the previous scholars that you mentioned, that the fact that in the Quran it says that you have been created for ibadah, for worship, then I think this is probably a very good criteria, if you like. Let's just elaborate that. So, for a person to be God conscious, has to be mentally with it. I could be physically unwell, unable to go to sujood and sit on the chair and pray. But if I am gone gaga, then it's unlikely, although I've never been myself into that position and come out, to understand how God unconscious or conscious that individual is. Very difficult. But I think as demented person or severely demented person, I think one can assume, and where we also quite happily say that Salah is no longer wajib on him now, yes, we'll feel fairly comfortable that he is not able to be conscious about God. So I think that is an excellent way, and if I just analyze few that I have managed, it is on that basis. I think that if that person has a severe dementia, and if the quality of life relating to that, so that would be a very powerful factor in terms of ventilating, whatever. But we must also distinguish that it is not the treatment that you're withholding. Yeah, there is subtle difference between proactive treatment and, if you like, managing his existing health. Yeah. So a pig feed is not really a treatment.
It's very invasive.
Yes. So drinking and eating is not treatment. Drinking and eating is a natural thing that happens. So if I am unable to drink or if I am unable to eat, you don't have to push it down my throat or down my tube, okay, under the pretext of treatment. It's not treatment. So I use all those examples, if you like, to try and pave a way where there is a joint decision making. I never have had a need to call an imam or a chaplain. I think I can relate, and I think the patient and the relatives and the advocates can relate quite easily about all these issues. And I think it's just a matter of guiding and matter of debating and matter of showing choices and letting them make a decision. And by and large, the decision is rightly made by the relatives. Of course, and your final point about where to die and how to die, I think death has to be as beautiful as birth. Exactly as a child is born and we all try and sort of parachute down to that house wanting to hold the child, wanting to kiss the child and wanting to be around the child and the baby as it grows for the first few months, I think last few months of death have to be exactly the same. So in an environment where there is love and affection, an environment that is familiar, No,
that's very, very helpful. Jazakallah.
Thank you. We have 4 other people waiting for questions, so if it's okay, I'm going to take them all together and then finish. So start Zulianka.
I better write them down now.
I think if we change the narrative from extending life to delaying death, we might think differently. Secondly,
can I ask you to expand on that?
Well, I mean, you're just delaying this gentleman, this patient who's already half dead, right? And you're just keeping him alive, really. I mean, it really is delaying death, isn't it? 1 to 3 months or whatever. Okay, so their patient already dead. And secondly, if the family had to pay for his delaying of the death, would they have called the imam? I doubt it.
Very useful. The resource question is always a very good
So
one.
I think it's a first world issue, not the third world issue, right? Thanks.
Absolutely.
Okay, Blanca?
There are three observations I want to make. One is that there is a related ethical debate when it comes to at what point you are allowed to harvest organs for transplant. Yeah. Now, obviously, that's a clear definition of death in the broadest sense. Yeah.
Mm.
So I think at that point, obviously, all the other medical resuscitation and things are not valid. So I think there are Muslim doctors who have worked on that and looking at stem cell death and whatever. If you, as a person, have authorized your organs to be used for somebody else or consented, yeah. So I think the two debates need to be related.
Absolutely.
So that will solve maybe a quarter of the cases which you are looking at, not all of them. The second question is related to what Zuli was saying, in the sense that if the funding pressures on the NHS become even more severe, as they are likely to be,
Exactly.
would the thinking of the medical profession change on this? Because of the funding, they can see if it's not something. So would their understanding of death become much more restrictive and say, fine?
What do you think about it, Uncle? I mean, how...
I mean, sociologically, this could be shown that it will happen. And finally, whilst what Nizar is saying is true, but I think your research will show you when you do your qualitative research that different people, different Muslims, come with very different cultural background, contexts, religious background as to how they view these things, right? And so some of them will insist on referring to the Imam. Some of them will not need to. Some of them may feel guilty because they haven't consulted. And I came across one case recently. We were talking to somebody we were traveling with, and he said, I couldn't do anything. My father, I had to hand him over. They had to section him, to take him away because he just couldn't. He wasn't able to do anything himself, and we were not able to decide whether. But now he has died. I'm still feeling guilty that we did the wrong thing. I was telling him, no, you didn't do the wrong thing. You couldn't do it.
Yeah. No, that's
but
very important.
you see the background. He was saying, but I have consulted 5 imams and 3 scholars, and each one is saying you should have done more. And this. So he's still 4 years, 3 years after the death of his father, he's still feeling that he did something wrong. And it's just impossible to convince him. So I think you will come across that. So the change will have to come to see, first if you can classify, say, these are the 10 kind of influences which people have. And then we go as to say how to address each one of them.
Each one of them, yeah, absolutely.
Especially the religious.
True.
Well, there is a mixture of religion and culture here. This is the other problem.
True.
So we might need to address both together. Then we can make some headway. So I think these are the 3.
No, Jazakallah, it's very, very important. And the considerations after death are very, very important. And it's one of the reasons why I want to talk to lots of different kinds of people at different stages, because there is a need in terms of counselling and bereavement services that, again, may highlight work that we need to do.
Arif, quickly. Arif, and then Ali.
Oh, sorry, I'm not supposed to talk in between. Wa alaikum salam.
Point quickly then. My very brief experience with talking to Muslim families when it comes to the do not resuscitate orders. if you take it from either the patient's perspective or the family's perspective, their main concern lies with not wanting to, with regards to the patients, I don't want to commit suicide. And from the patient's family side, we don't want to commit murder, being that we only have one death in this life, we have to do it properly. And we can't live with the consequence of, for example, the patient, if I'm going to die, but I know there's a treatment which will bring me back to life again, if I don't take on that treatment, I'm committing suicide, and therefore I will be condemned to eternal punishment. And of the same perspective from the patient's family side, being that how can we withhold the treatment, because if we don't give the treatment, then we are therefore committing murder. And I was having this conversation with a patient of mine, and he said about, I would have no problem with it, it's just I don't want to be committing suicide. And I said, I completely understand, but if your heart did stop beating, you would have died. You can't commit suicide after having died. It only is by the fact that you're in hospital and we're around that we may be able to restart your heart, for example, through very invasive procedures, as we know. But if you were at home and you had this, you would have died. And I think for time's sake, I'll just leave it at that, actually.
Yeah, no, I mean, it's a very, very, very important point. I know it's naughty of me to say this, but when I've come across that situation, there's been somebody who's quick to say, well, nobody can bring the dead back to life, so technically that person's not really dead. But we'll end up down a rabbit hole, so I won't unpick that further.
Ali, final question, and then inshallah.
Actually, I think my comment is a bit long. I was going to take devil's advocate and actually support why we have this difficulty. I'll try to make it quick. I get the impression that everyone is taking the side of the angel of death, and I'm going to take the side of angel of life, because especially from Muslims, when there's difficulty with DNAR orders and the issue of death and suicide, etc., well, there's a misunderstanding on one side. But on the other side, with experience, obviously everyone has seen what we've been through, and is that usually the doctors are saying that we need to withdraw and the patients are saying the other way around. But there have been plenty of cases which are the other way around, and the judgment of where the medical futility has arrived is very subjective, and different physicians will have different experiences and opinions, and it boils down to human error. And this is what we want to minimize. So if I have a patient relative, I would be absolutely adamant that I do not want a DNAR order until I've seen all of their medical records, because the number of, so I can, several examples in my mind. One where the patient was judged to be dying because she was 91 years old, and so they withdrew all treatment. She was being poisoned by drugs, so when they withdrew treatment, she recovered and she lived for a very long time afterwards. Or another case where she had an infection and she deteriorated, and it was clear that she was dying to everyone. So they stopped treatment, except for us in our specialty, because she was lacking a certain drug, and you give it to her and she's back to her baseline. She needed more of it during the infection. And again, she lived much longer than expected. Or a relative who has still lived 5 years, despite them wanting to withdraw treatment, nutrition, antibiotics, had a heart attack and then a stroke, and then another heart attack and another stroke and a hip fracture. So they said, this is the end, everyone can see. But 5 years later, she's still here, and she has a quality of life. So what I'm trying to paint is a spectrum of life. And when we say we value life, we need, yes, of course there's death. But I think when doctors decide that it's a very difficult decision, and it's always a difficult conversation, but you say, as doctors, we're always trained to prolong life, increase health, quality of life. But there comes a point where we can no longer do that, and we fail. And that's when we withdraw treatment. But then that boils to an opinion and to the variety of treatments that are available. So with time, this will change. In the past, when people had, severe TB, and they were young, they would die. It was a death sentence. and you would withdraw treatment. That would be crazy nowadays. And dementia is like that now. I can easily foresee a future, and there will be. It's just a matter of time when it won't be anymore. And so this is why I fully understand the problems that patients have, and I think that doctors actually underestimate this. There are also other cases that are clearly, everyone medical professional will say they are dead until a couple of 7, 8 years ago, when they scan their using functional MRI, there's dead. Every test shows that they're dead completely. But functional MRI shows when you talk to them, can you play tennis? They're playing tennis in their mind. Can you imagine a cup? They're imagining something. That's in the right category. So they have activity that we've not been able to foresee. So then who are we to judge whether they would prefer this minimal life compared to us? And just because they're not like us, their life is not like us. So I think it's, I don't know, I just wanted to make these comments to play devil's advocate.
No, it's very, very valuable. And it relates to what Uncle was saying in terms of how we define death and what the definition of death then means in terms of its implications for organ harvesting, etc. So, and it's one of those things because of the advancements we're seeing. It's an evolving space, which is why it's all the more important that we keep talking and keep playing devil's advocate, because it can't be simply in the hands of one type of knowledge or sphere to make these sorts of decisions. It's something that needs to be shared. Were there any more? No? Yeah, well, I think those were sterling pieces of advice rather than questions per se. I can't disagree with any of what was said. The comment that was raised about distinguishing between or making clear between extending life versus delaying death, I think it's important we consider that, but that's reflected on the last comment of how we define death, and that these all need to be contextualized and considered on a case-to-case basis. The issue of harvesting organs, I do want to spend a little bit of time reflecting on. There was a case recently in Luton of a lady who, a Muslim lady who became acutely unwell. Her family decided that she would have wanted her organs to be harvested. The hospital said that they would organize everything in relation to the harvesting of the organs and her burial, etc. And the hospital chaplain came to visit the family, and they discussed it with the chaplain. And then later that day, somebody from the funeral service came to visit the family. And the person from the funeral service said, would you like me to organize the death certification and the burial process? So the family said, look, no, actually, the hospital are going to be doing this all for us because we've consented to her organs being harvested. And the funeral director said, no, you can't do this. This isn't allowed. And so the family suddenly became very, very anxious. And because they knew that the funeral services would have to go through this particular director, and that would then have implications for the janaza salah, etc., they revoked their consent for the organ harvesting because they didn't want to do anything that he'd be in disagreement with. So I just want to end on that note in terms of who it is that becomes involved in these sorts of decisions, and what the lines of authority are, and how these become commonly misunderstood and blurred. But Jazakallah so much, Jazakallah for your time.
Thank you very much. Salawat.